Hello, my name is Anna Marie Samuelis, Field Product Manager for Cancer Genetics. Thank you for joining us. This presentation will provide an introduction to FHACT, our FISH-based HPV Associated Cancer Test. Today we will focus on the need for FHACT and its role in the cervical cancer screening program. After today's session, you will understand the limitations of today's cervical screening process, the need for an assay that will show the patient's cervical cellular reaction or lack of reaction to a viral HPV infection, how the ASCCP is looking to implement HPV testing as the primary screening test for cervical cancer, and how FHACT fits perfectly into the cervical cancer screening process. Today's menu for cervical cancer screening include thin layer liquid-based cytology such as ThinPrep and SurePath. Both utilize computer-assisted screening. Cytopathologists manually review all abnormal cervical smears. Of course, there's the widely used HPV testing and genotyping, as well as various immunohistochemical and molecular tests which are ordered by the cytopathologist to help clarify a difficult case. What are the problems with these current tests? First of all, none of these tests can tell you which individual woman with abnormal cervical smears will experience disease regression or significant disease progression. Cervical smears present too many false negatives because of poor sensitivity. HPV testing exhibits too many false positives because of poor test specificity. Looking at the test performance, there has been a significant increase in test sensitivity moving from the manual Pap smear at 51% onto the thin layer technology, which is now about 82%. The predictive value of a negative HPV test for the absence of cervical cellular disease is very high, whereas the predictive value of a positive HPV test for the presence of cervical disease is very low. Often, if these tests are abnormal, women are sent on to colposcopy. The ALTS study showed that 28% of LSILs will have situ plus upon biopsy, whereas 42% of situ lesions were missed on an initial colposcopy. HPV infections are rampant worldwide. Global statistical analyses have demonstrated that HPV infection is essential for the development of cervical cancer. HPV DNA has been found in 99.7% of cervical cancer specimens. There are over 200 types of HPV known. Only about 15 HPV types are considered high risk for the development of cervical cancer and are responsible for 98% of all cervical cancer. In particular, HPV 16 and 18 are responsible for 70% of squamous cell carcinoma and 85% of adenocarcinoma. It is still possible, however, for other strains of HPV to cause cervical cancer. It is also important to appreciate that most infections by high-risk HPV types do not even cause a cytological change. What is also important to note is that 90% of HPV cervical infections clear from the body without treatment within about 2 years of infection. This means that few precancerous lesions will actually progress to cancer, and those that do progress are the result of persistent HPV infection, which causes irreversible damage to the DNA of the cervical cells. The HPV status of a person is determined by HPV testing, which can detect the presence of high-risk strains of HPV. Several HPV tests are available, but each has its own limitations. Each test detects only certain strains of the virus, and although strains 16 and 18 are responsible for the majority of cervical cancer cases, recent work indicates that there are differences in high-risk strains across diverse and changing populations. For example, strain 66 is becoming high risk in Houston, Texas. Furthermore, the presence of a high-risk strain does not necessarily indicate a persistent infection, and by itself has little predictive value of progression to cervical disease. In 2010, CAP Today published an important article in which some of the leading authorities in cervical cancer screening acknowledged that the current cervical cancer screening tools cannot predict which individual lesions will progress to cancer. They clearly indicated that we must have a tool to tell us whether or not an HPV infection has actually done damage to the patient's cervical cell DNA, resulting in a gene change that represents a step in the malignant transformation of that cell. In other words, a test that looks at the host's cellular reaction to the HPV viral infection. This is why we need FHACT. This slide depicts an overview of the current most widely used algorithms in cervical cancer screening. Knowing the limitation of the current testing menu, we believe that incorporating FHACT into this process will assist clinicians in finding those HPV-infected women who have experienced potentially malignant genomic transformation from those millions who have not. When a woman has an LSIL or an ASCUS HPV positive test result, performing FHACT will give the clinician important information whether that woman's HPV infection has integrated into her genome, causing a DNA mutation that is irreversible and, if left untreated, has the potential to progress to significant pre-malignant or malignant disease. FHACT is truly personalized medicine. To demonstrate this need for better testing, let's look at the distribution of cytology and HPV testing results in the U.S. Of the 55 million Pap smears performed annually, about 1.7 million have normal cytology and are positive for high-risk HPV. Of the 1.65 million ASCUS results, about 500,000 are positive for high-risk HPV. These 30 to 40% are likely to be sent to colposcopy as per current guidelines. Similarly, of the 500,000 LSIL PAPs, nearly 70 to 90% are positive for high-risk HPV. These women are also sent to colposcopy. Between these two groups, about 2.6 million women with low-grade or undetermined abnormal lesions are being referred to colposcopy. As you can see, the 5-year risk of ASCUS and LSIL high-risk HPV-positive women is nearly the same as that of an HPV-positive woman with normal cytology. The 2.6 million women expressing HPV-positive and abnormal PAP results need a better test to triage them appropriately while not performing unnecessary tests that are costly and can cause damage to their cervix, causing fertility and delivery problems in those who are of childbearing years. Let's learn how FHACT will improve this situation. We know that HPV infection is necessary but not sufficient for tumorigenesis. When HPV infects the cells, it produces proteins that inhibit cell cycle control proteins in the host cell. One HPV protein interferes with host proteins that stop damaged cells from growing, and the other interferes with proteins that make damaged cells commit suicide. This combination of uncontrolled cell growth and prolonged survival is what ultimately leads to genomic instability, which is one of the hallmarks of cancer. There are two goals, therefore, of implementing additional biomarkers to screen for cervical cancer. The first is to improve HSIL detection, which is the medically actionable group of SIN2 and SIN3. The second is to identify ASCUS and LSIL cases that are likely to progress to HSIL. We currently have ongoing studies that will help us achieve these goals. As of now, we do not associate any predictive value with the results, as we will discuss in more detail later. Our hypothesis, therefore, is that host genomic abnormalities precede tumorigenesis. Genomic instability can manifest as chromosomal translocations and DNA mutations, as well as copy number changes, including gains and losses of chromosomal regions. Developing cervical cancer necessitates an HPV virus infection within the host cervical cells. HPV infection indicates a woman is at risk for cervical cellular disease, not that she has cervical cellular disease. The hallmark of malignant transformation, genomic changes in the cervical cellular genes, is revealed by FHACT. By now, all have heard that the FDA approved the COBUS HPV test to be used for primary cervical cancer screening. On the surface, it makes sense to first test for the causative agent HPV. This will show clinicians all the women who are at risk for cervical disease. Certainly, if HPV is negative, there is no concern. But if HPV is positive, you then need to distinguish which women are in the minority group that true disease progression from the majority of women who do not have disease progression. We believe that FHACT will give you that answer. Let's look at how it applies. By utilizing FHACT on those women who are positive for HPV, you will identify those at greatest risk for the disease progression. Those women positive for FHACT need to be followed closely and acted upon to remove those lesions that, if left alone, would progress. As we have demonstrated, the current screening workflow often can lead to overtreatment because of the shortcomings associated with cervical cytology and HPV testing. The Pap test has poor test sensitivity, meaning the Pap test is read out as normal when cervical cellular disease is actually present. Interpreting cervical smears also has poor inter-observer reproducibility as well as poor inter-laboratory reproducibility. HPV testing has poor test specificity for the detection of cervical cellular disease because most HPV infections, even those caused by high-risk HPV viruses, do not even cause a cytological abnormality in the cervical infected cells. The HPV test is positive for the presence of HPV virus, but no cytological cellular abnormalities are present. As a result of these shortcomings in cytology and HPV testing, too many women are sent to colposcopy and have biopsy procedures performed. This is illustrated by the fact that of the 1 million colposcopies performed annually on ASCUS or LSIL lesions, about 43% come back with a normal result. Furthermore, only about 20% of LSIL lesions are medically actionable. Now, let's take a look at FHACT. FHACT is a 4-probe FISH fluorescent in situ hybridization test. The 4 loci chosen for FHACT are 3q26, 5p15, 20q13, and centromere 7. Gain of the TERK gene, 3q26, has long been associated with precancerous and cancerous cervical lesions. Gains of 5p15 and 20q13 have also been reported in HPV-associated precancer and cancerous lesions. Centromere 7 was originally chosen as a ploidy control, but as we will highlight, centromere 7 actually turned out to be a significant marker associated with more severe lesions. We elected FISH as the methodology of choice to introduce these biomarkers into the cervical cancer screening process for several reasons. FISH is a technique that presents several advantages over other less sophisticated technologies, including good resolution, quick turnaround time, high specificity and sensitivity, as it is possible to detect one positive cell among hundreds. FISH allows direct assessment of the patient's genome. It is non-invasive, and it is less subjective than cervical cytology. The test is performed on the residual liquid-based specimen utilized for cytology and HPV testing. Here we have a table summarizing the frequency of gains of the FHACT loci in the publicly available Cancer Genome Atlas dataset. This dataset includes 114 samples that have been assessed by array CGH for gains and losses of chromosomal regions. Dr. Jane Holdsworth analyzed this dataset for gains of the FHACT loci and compiled this table, which provides interesting insight into the observed frequency of gains of these 4 markers. As you can see, gain of 3q26 has the highest overall frequency at 79%. Interestingly, gain of 20q is observed in nearly the same frequency as gain of 5p. Also of note is that gain of SEN7 is observed with a frequency of 14%. So although originally intended as a ploidy control, SEN7 is actually showing gains in some cervical cancer samples. This is important to note because some other FISH tests still use SEN7 as a copy number control. You can see that of the 114 samples, about 90% show gain of 1 or more of the 4 FHACT loci, compared to only 79% showing gain when screened only for 3q26. Please note that the data on this slide is from our study with the NCI, which was published in September 2013 issue of Gynecologic Oncology. When analyzing our results for correlation of copy number changes with lesion severity, no correlation could be seen when scoring the conventional way with 2 observers each scoring 100 cells. There was also no correlation seen when samples were scored with a bias toward epithelial-like cells. However, a correlation was seen when at least 1,000 cells of all types were scored. At 1,000 cells or higher, the frequency of gain of each locus increases with increasing lesion severity. So this data supports scoring all cell types, including both epithelial cells and leukocytes, with no bias toward size or shape. The data was also evaluated excluding tetraploid cells and cells with gain of only 3 signals. No significant difference in correlation was seen. So in this case, 3 or more signals per locus was considered positive for gain and tetraploid cells were included. Another important point is that the ploidy control, SEN7, also shows gain and a correlation with lesion severity. So although originally intended as a ploidy control, centromere 7 turns out to be a significant marker in precancerous lesions. Here is a look at a sample report. Here at Cancer Genetics, we score a total of 2,000 cells. We have determined cutoffs for each locus as per CLIA guidelines and report each locus separately as gained when observed above the defined cutoff. So we are only reporting presence of gain or no gain relative to the cutoff values. As we mentioned earlier, we are hoping to be able to associate predictive values with the FHACT results in light of further ongoing studies. In summary, the majority of low-grade, high-risk HPV-positive lesions, about 90%, will regress within 2 years of infection, whereas potentially 10% will progress on to a higher grade within 10 to 30 years of infection. Yet because of lack of appropriate tools for testing, many women are referred to invasive colposcopy and biopsy procedures. Therefore, there is a need for a tool to distinguish women with low-grade, high-risk HPV-positive lesions that will not progress from those with low-grade, high-risk HPV-positive lesions that will progress. FHACT is indeed that tool. CGI's solution is to include the FHACT test as an adjunct to cytology and HPV testing prior to referral of colposcopy. FHACT can be performed on the original liquid-based sample with no need for additional sampling, and can help reduce the number of women referred to colposcopy and biopsy by only referring those women whose lesions show markers of high-risk lesions. Importantly, reducing this number can also reduce healthcare costs. This is a cost-effective, personalized medicine test. Know your patient's FHACT. Thank you for participating today, and please feel free to browse our website at www.cgifact.com. Contact us directly to learn how to incorporate FHACT into your women's health testing menu.